The topic of PIPs are getting over. We are coming to down proximally on the metacarpophalangeal joints. So, acute and chronic dislocations. Just a single slide will sum up the anatomical mechanics of this MCP. The intermetacarpal ligaments getting attached to the volar side and giving stability to the volar plate, and subsequently, and plus additionally the proper collateral and accessory collaterals will form the box-like structure. So intermetacarpal ligaments shown over here in between the metacarpals, the proper and accessory collaterals and the volar plate on the front will give stability to the metacarpophalangeal joints. The metacarpal head has a cam type configuration. Now this diagram is from the greens. If the metacarpophalangeal joint is kept in flexion, the collaterals are at its length and it gives the maximum stability. That is the mechanical basis of the functional position of the hand also, wherein MCPs are kept in around 50 to 70 degrees of flexion to keep the collaterals at length. Dorsal dislocations are the commonest patterns. Volar are rare but reasonably noted in literature. Now, simple versus complex, how can you differentiate? Just looking at the finger position, the proximal phalanx is postured in quite a lot of hyperextension. Then it is simple, where the volar plate is still not interposed into the joint, where when it becomes complete, the metacarpophalangeal joint is held in slight extension where flexion is impossible. And commonly seen in Kaplans in the index finger, the metacarpal head will be prominent in the palm, and soft tissue puckering will be seen on the dorsal aspect of the metacarpophalangeal joint. So that's how you can differentiate whether it's simple or complex. Now this is what I meant. This is the clinical picture where it is a neglected metacarpophalangeal dislocation. You can see a puckering here. On the dorsal side, there is some puckering. The proximal phalanx is held in slight extension. You can see the dislocation of the metacarpophalangeal joint, where the proximal phalanx turns towards the adjacent digit, and you can see a small osteochondral fragment also along with, which should be diagnosed with a Brewerton view, wherein the metacarpophalangeal joints are flexed at around 60-65 degrees. The fingers are placed on the plate. That's where, if along with dislocation, if there is any osteochondral fragment, you can diagnose it at the metacarpophalangeal joint level. This is one more X-ray which is crucial to pre-operatively diagnose if there is any fracture associated with. Maneuvering simple dislocation, flex the wrist to relax the flexors, and then push distal and volar pressure to the dorsal base of the proximal phalanx, and start the flexion of the metacarpophalangeal joint early. Dorsal blocking splint to prevent extension beyond neutral for 4 weeks to get the best possible functional outcome. Complex dislocation, volar approach is recommended because you don't want to intervene onto the extensor expansion. On the index finger, the radial neurovascular bundle will be very close and will be immediately below the areolar tissue, and in the little finger, ulnar neurovascular bundle. In a Kaplan's dislocation, the muscle tendon noose, the lumbrical and the flexor noose will be at the level of the MCP neck. Even pulley release will facilitate the easing out of the tension on the flexors, and no soft tissue repair is necessary as you reduce the joint. Immobilize the joint in 30 degrees of flexion for first 2 weeks and start with active motion immediately at 10 degrees of MCP flexion for further two more weeks, and buddy tape, as Warrior sir was explaining, to the adjacent digit at 8 weeks. Now this was the case where we did it with Dr. Parag. Now you can see here, this was a child with problem in the thumb. He was here again. It's there in the folder. The video is not playing.
It is in the folder. Not in the
Kiran, let it be.
Okay.
Go ahead, move ahead.
So we approached it on the volar side. You can see it, the radial neurovascular bundle and the flexors. As you as you retract the flexors here, you can see a volar plate tethering on and which is causing the loss of reduction. As we reduce it, this is the post-operative X-ray, and this is the function at around 3 months. This is a case of open volar MCP dislocation. This was a bad injury due to fall on the gravel. Now you can see the flexors are also getting out of the wound here, and the surface what you see here is the proximal phalanx base which has come out through the wound. As we debrided the tendinous part, this is how the wound looks like. This is the preoperative X-ray where the proximal phalanx is dislocated volarly, and we could see the tendon getting out of the wound. But since the FDP was intact and this was irreparable, we just continued with the reduction. We extended the wound here, got down the reduction of the joints. The soft tissues, the deeper soft tissues like volar plate and this thing fell back in place, and we could get a congruous reduction here, and a good position of the fingers, and getting a better outcome slowly. This is just an initial follow-up right now. So anatomy is crucial for planning the treatment, understanding the anatomy. Radiographs to rule out MCP head or osteochondral shear fractures, and protect the neurovascular bundles with a careful skin incision and the blunt dissection of the neurovascular bundles. A1 pulley release is crucial to retract the flexors to take out that noose around the metacarpal neck, and soft tissue repair as necessary in particular fracture patterns. I thank you for your kind attention.